Welcome to this iHF webinar entitled Should Atrial Fibrillation Ablation be the fifth pillar in heart failure management with atrial fibrillation? As you know, the recent guidelines mention that 4 drugs should be given to patients with reduced ejection fraction, but we have to keep in mind that about 30 to 50% of them have atrial fibrillation. So how to manage atrial fibrillation in this specific population? So we will give you evidence, benefits, and also, importantly, patient selection and follow-up care. Whatever your subspecialty in cardiology, or even if you are not a cardiologist, and if you want to learn about the summary of major studies highlighting the survival, hospitalization, and improvement in quality of life in patients with heart failure with reduced ejection fraction. If you want to know how to better identify your patient with heart failure who could benefit from atrial fibrillation. And finally, and very importantly, we have to stress the importance of risk factor management and patient-centered care in heart failure after AFib ablation. And now I hand over to Izabella to present the team.
Of course, and I have a great pleasure to introduce the panel of experts who join us today. Professor José Luis Merino from Spain, electrophysiologist, Professor Axel Brandes from Denmark, cardiologist, and Professor David Duncker, electrophysiologist from Germany, and my colleague who is a coordinator today, Christophe Leclercq, who is from France.
And don't forget to introduce you, Izabella.
Of course, Izabella Uchmanowicz, a nurse from Poland.
So now we will start with a case. As you know, iHF webinars are based on clinical cases. It's my great pleasure to welcome David Duncker, which is an electrophysiologist in Hanover, Germany, to present this case of a patient with heart failure, reduced ejection fraction, and atrial fibrillation.
Yeah, thank you very much, Christophe. It's a pleasure to be with you and present a patient from Hanover that we treated in our center. So this is the patient, 62-year-old man. He had a non-ischemic cardiomyopathy, was in New York heart status 2, ejection fraction 30%, and he recently had a CRTD upgrade from a DDD pacemaker 18 months ago, but he presented with a reduced biventricular pacing of only 85%, and this was mainly due to persistent atrial fibrillation that led to 2 hospitalizations within the last 5 months. He also had a cardioversion and was on amiodarone. He had some comorbidities, a BMI of 31, arterial hypertension, diabetes, and moderate alcohol consumption. His medication was quite good. He had an RD, beta blocker, MR antagonist, SGLT2 inhibitor, and a NOAC. But the amiodarone was stopped after a short term for hyperthyreosis. His CHEST-2 VAS score was 3. And we made some investigations. So the echo showed a reduced ejection fraction. LVEDD was 62 millimeters. He had a slightly dilated LA and a mild to moderate mitral regurgitation. The device interrogation showed an AF burden of 35%. The biventricular pacing had dropped, and the ventricular rate during AF was elevated of 110 to 130 beats per minute. The labs showed NT-proBNP was 1,800. This was his ECG, and you see the X-ray. He had an upgrade and slight elevated lead account on his chest X-ray too. So the question now was, we have a patient on optimized guideline-directed medical therapy with a high AF burden and an under-delivering CRT. And the question is, which option should we choose now for this patient? And we ask you in this first poll. First is escalate rate control, or 2, antiarrhythmic drug re-challenge to retry amiodarone that we had to stop for hyperthyreosis, or 3, AV nodal ablation, or 4, catheter ablation for AF.
Thank you, David. So you have a few seconds still to vote and to tell us what will be your strategy. And I can just give the result very quickly. There was about 25% for the escalation of rate control, 10% for the rechallenge with amiodarone, 35% for heavy node ablation, and the majority for catheter ablation.
Yeah, well, let's say that, of course, all these four are options, and there is no right or wrong. There's a choice to take. But we took the choice of catheter ablation, like the majority, and I will present the results later.
Okay, thank you for this very interesting case. I was sure that it will be a tricky question, and it was. So we will move now to the mini lecture presented by Professor José Luis Merino from Spain, who will explain the rationale for atrial fibrillation ablation.
So thank you, Izabella. Thank you, Christophe. It's a real pleasure being today here with all of you and with this very interesting case. And I will try to discuss with you the potential reasons to support the choice that David did and their team. We know that atrial fibrillation and heart failure are both epidemics, pandemics, in fact, in the 21st century. But we also know that each of these diseases potentiates the other. So the old aphorism of atrial fibrillation begets atrial fibrillation now has been converted into atrial fibrillation begets heart failure, and heart failure begets atrial fibrillation, because one and the other interact. But what are the hemodynamic consequences of atrial fibrillation? Why atrial fibrillation begets heart failure? There are several factors involved. Some of them are well known and well acknowledged, like loss of atrial kick or elevated heart rate that, by the way, this patient had. But in addition to these two factors, there are other two that may play a role. One is the loss of heart rate adaptation to the metabolic demand, and very important, irregularity. Irregularity itself may decrease cardiac output and may increase pulmonary wedge pressure. So these are the hemodynamic consequences. In addition, whenever you look at atrial angiogram in atrial fibrillation, although you immediately recognize that this should be associated with important clinical consequences to your patient. This is something that is obviously related to poor outcomes. So these are the physiopathologic reasons to justify ablation in this kind of patients. But what are the clinical evidences? And there are many trials that have explored rhythm and rate control in heart failure patients. But I would like to discuss with you three main important ones. That is, the first one is the catheter ablation for atrial fibrillation with heart failure, the Castle EF trial, published in 2018. And this trial enrolled patients with an ICD that were randomized to ablation or conventional therapy of heart failure. 400 patients, 200, 200, and at follow-up, the two arms showed significant differences in terms of the primary endpoint, death or worsening of heart failure or hospitalization due to this reason. But not only the primary endpoint was statistically different in favor of ablation, but also the secondary endpoints, the composites of the primary endpoint, death from any cause or hospitalization due to worsening of heart failure. So this trial was clear. Maybe the size was not quite large, but then there was a second trial published 1 year later, the Cabana trial. This trial enrolled over 2,000 patients. They were not only heart failure patients, they were a regular sample of atrial fibrillation patients, randomized to ablation or to drug therapy. There were several limitations of the trial, like a huge crossover between the two arms, and in the intention to treat analysis, there were no differences between the two arms. However, looking into the individual characteristics of the patients, and specifically in patients with heart failure, you see on the slide that patients with no heart failure saw no differences in terms of prognosis in the two arms, ablation or conventional therapy, but those with heart failure behave better with atrial fibrillation ablation. Finally, the last trial that I would like to discuss with you is a kind of evolution of the Castle EF trial, that is the Castle STX. And this trial enrolled patients with end-stage heart failure, or even in the waiting list of heart transplantation. And these were 200 patients randomized again to ablation or conventional medical therapy. The endpoint was a composite of mortality and heart transplantation or LVAD implantation. You see here on the slide the primary endpoint that showed striking differences in terms of better survival in the ablation group. And also, if we analyze the secondary endpoints, death from any cause was significantly decreased in the ablation arm compared to medical therapy. So if I, not to extend myself much longer, if I needed to give you 3 final messages, number 1, there are clear physiopathological factors supporting ablation in these heart failure patients. Evidences, number 2, clinical evidences also support ablation in heart failure patients. And number 3, all these 2 reasons justify why ablation, catheter ablation, should be the 5th pillar in heart failure treatment. Thank you for your attention.
Thank you, Jose, for this wonderful lecture, because it was a short time that you can present, but now we can move into discussions. So the audience can ask questions on chat box. So Christophe will check this out, and we can now discuss if we have any questions and comments.
Yes, do not forget to send your question via the chat box, and we have already a question. Just a practical question. We just got David about the management of anticoagulants in the setting of ablation. The question is, do we have to stop a few days before the anticoagulant because the patient will undergo an interventional procedure, or should we keep the anticoagulation?
Yeah, this is something we learned in the last years, and which is now very, very clear. We usually do all procedures on uninterrupted anticoagulation, which means for a smaller part of the patient on continued warfarin, but the larger part of the patient, of course, has a non-vitamin K antagonist, and now should receive this continuously. And continuously means we only skip the dose of the morning of the procedure and then continue already in the evening after the procedure with the NOAC.
I have another question more for you, José, because we discussed about patients with reduced ejection fraction. And what are the evidence for patients with preserved ejection fraction? Do we have the same level of evidence that AFib ablation may improve survival, decrease hospitalization, improve quality of life in the 2 settings of heart failure?
Yeah, this is a very good question. In fact, the 2 trials that were specifically analyzing the benefit of the potential benefit of catheter ablation in heart failure patients were HFrEF. So no, these trials didn't enroll HFpEF. However, the Cabana trial that I presented also enrolled HFpEF. And it's true that it's not, it was a sub-analysis, but supported also the benefit of catheter ablation in this population. And this explains why there are ongoing trials specifically analyzing the role, potential role of catheter ablation in HFpEF, and we'll see in the near future. There is still several years after we will have the results.
Okay, thank you. And I have an easy or uneasy question, what we are discussing today a lot, about patient-shared decision-making, because it's a new concept and we see this in every guidelines actually. So if you could, David, tell us your opinion on how you deal with this, because you have to talk with the patient, what does he want or she wants, and how can you manage this as a physician?
Yeah, I think, as you said, the guidelines recommend it, and this is a strong recommendation. We cannot overemphasize this. And on the other hand, this is something that is, of course, time-consuming, so we have to deal with it. We not only have to plan the procedure, but also plan the discussion with the patient. But I think it's important to discuss about, of course, benefits and risk of a procedure, but also of alternatives. Because for AF, for example, the alternative is antiarrhythmics versus catheter ablation, or even more versus patient ablate. And all are valid options, and we need to consider ourselves, of course, what is the best option for our patient, but we need to take the discussion with our patient too, because patients sometimes have different perspectives and different priorities also. Maybe the priority is, I want to go to a hospital once, but then never again. So then we need to take this into account. And I think we need to discuss this before we take any action. And then, of course, during follow-up too, because we are not only ablationists, because we like catheters, we also need to follow up our patients, and the patients will have atrial fibrillation and heart failure 2 years later, just as well. And yeah, we sometimes forget this in a fast medicine where we take decisions within minutes, but the patient will stay there for years.
Yes, because of the shortage of time, sometimes we forget that the patient, in order to adhere to medication and to your recommendation, they need to know what they're supposed to do, right? And they need some follow-ups.
Mm-hmm. Absolutely.
Yes, we have an interesting question about patient with FREF, about the timing of ablation. And it's one from Dominique, a very good colleague we know very well. And the question is, if you consider the ERA classification about symptoms, do we have still to stay at ERA 2, or do we have to move to ERA 1? That means that the patient is asymptomatic. In patient with FREF. It's a difficult question.
It's already a difficult question, I think, in patients without heart failure. And I think the guidelines in patients without heart failure are already very clear, because catheter ablation is not only indicated for symptoms, but also for reduction of progression of AF. So I think this is the way to go, but clearly to discuss even more with the patient. What is the goal of this therapy? For HFrEF, I think it is difficult, because if you have a heart failure, the patient usually is not asymptomatic, and sometimes it's not easy to differentiate what is heart failure symptom and what is AF symptom. So I don't know if this patient really exists, but nevertheless, I think that especially in HFrEF patients, it's important to treat the patient early. And this means we should also discuss about early atrial fibrillation ablation, for sure.
I have a question for all of you. You have a patient with FREF, well treated with 4 drugs. The patient is still with a low ejection fraction, but the patient is in AFib, and the patient tells, no, I am not symptomatic. Do you perform sometimes cardioversion to compare before and after the sinus rhythm restoration, if the patient is really asymptomatic? Because sometimes it's a concern to be sure that the patient is really asymptomatic, and asymptomatic at 25 years is different than at 80. So what is your practice? Do you perform sometimes cardioversion?
Absolutely. And I discussed this with the patient. Okay, you seem to be asymptomatic, but maybe you feel even better if we get you to sinus rhythm back again. And this is a trial, and if you discuss this with a patient, I think it's very feasible. It's an easy procedure, and then you re-evaluate the patient after some weeks only. So the most of the patient really will tell you, okay, I feel better now. Please, let's keep sinus rhythm.
And ablate me.
And keep the sinus.
For both of you, the same? You perform sometimes?
Yes, yes, we do, indeed. And sometimes you are surprised because the patient says, yes, I have never had a better life after DC cardioversion. So we do it. But there are also, we must admit, there are also patients who do not benefit from, and they are as symptomatic as before.
Yeah. It's true. The challenge is that you need to keep the patient in sinus rhythm for a while.
Yeah.
So if you carry over the patient and the patient is back into atrial fibrillation in 2 days, it's difficult because also you need some time to have a full recovery of the atrial contraction and so on. So still you need some days in sinus rhythm.
And sometimes you may prescribe amiodarone for a short time to better maintain the sinus rhythm and to avoid long-term complication. I would like now to come, if you agree, Izabella, to come to the question from David Duncker for your case, because it was a young man, 62, which is very young, I agree. And so he has a CRTD, he has a poor biventricular capture. So you propose first the escalate rate control. This patient was already under beta blockers. So do you expect really to better rate control this patient?
Well, let's say that could be one aim of the therapy. It was not our choice, but obviously he's in an elevated heart rate, and this reduces his biventricular pacing rate. So I think it is a valid aim. If you want to do it, if he's on maximum beta blocker dosage, you would need to add digoxin or even amiodarone for rate control. It's not the first choice, but it could be an option. I would not do it, but on the other hand, for short-term actions, it might be something just to bridge him to another therapy. So I would not say digoxin is wrong or something like that. It is not a good long-term choice, I would say.
No. And the issue, because José reminded us that from the pathophysiologic point of view, you still have irregularity, and I agree with you that irregularity in terms of cardiac output is very bad, and I think it's important.
And maybe one point, even if we have the rate dropped to 80, CRT will still not work well. So I don't think this is a long-term option.
No. About 10% of our colleagues decided to try again amiodarone in this patient who had hyperthyroidism. Which is, for me personally, a total contradiction, except if you decide to go to surgery and to retrieve the thyroid. But for me, I will not play with this game. What is your feeling for that?
I totally agree. I would never restart amiodarone if it has induced thyrotoxicosis once. So that's not an option in my opinion.
No. Okay, most of the colleagues were for ablation, but some of them were for AV node ablation and probably now CSP, conduction system pacing. But I think for me it's a very good option in a patient with 80 or something like that. But for 62 men, to be totally dependent of pacemaker, and I think it's a little bit too soon. Do you agree with that or not?
Yeah, I fully agree, because also lead replacements and so on. And also, I think that the best physiological pacing is spontaneous conduction, so the conduction system. So,
well, in fact, we all think the same. Okay, let's not do this too early. But on the other hand, the data for AV nodal ablation in this patient cohort is excellent.
No.
So I don't think it's a bad option. But yeah, obviously we chose another one because I think sinus rhythm is the easier and better and more physiological rhythm. But I don't think it's wrong to choose AV nodal ablation in this patient because he already has a CRT.
Yeah.
We will not change this. We will not explant it for any reason except infection maybe, but this patient will have CRT for the rest of his life, so he could also benefit from AV nodal ablation. And as I said, sometimes patients don't want to have ablation, another ablation, third ablation, and then AV nodal ablation. So maybe this is something we can discuss. But yeah, again, the physiological rhythm is sinus.
In fact, we are conducting a trial, the Abacus trial, you know it, that is it's not CRT, but it's AV nodal ablation plus conduction system pacing versus AFib ablation. So you are totally right that both options are acceptable nowadays.
I think we should have the answer of this trial in a few years, but I think if we decided to conduct this trial, it was because the question was not so clear. And I have another question, always from Dominic. If PVI, pulmonary vein isolation, failed, how fast should we consider PACE and ablate strategy by AV node ablation? Because you mentioned that sometimes we need several ablation to have a final result with a long-term sinus rhythm. So for your patient, you will show us something different, but do you consider quickly AV node ablation if you have one PVI with a failure, or you try again systematically, at least another one or two or three?
I think we don't know, and I think if we don't know, it's one more argument for discussing this with the patient. But if we go for PVI, then I think we should not be too fast for AV nodal ablation, because we know that we need some time for the atrium to restore. Especially in heart failure, if we have some remodeling, then this also requires some time. So I would not go for PVI and AV nodal ablation within months. But this is something to discuss with the patient. It's also valid to say, okay, we try one PVI, and if it fails, then we go directly to AV nodal ablation to have let's say, the problem solved. And this is an aim that often the patient brings to us. So yeah, this is something to discuss. I'm not aware of any data on this and dedicated timing studies on that.
A final short question for you, José. Which type of patient, which type of atrial fibrillation were included in the 2 Castle IF trial?
Yeah, it's true that there was no real exclusion criteria. So in the Castle XTX, for example, most of the patients were persistent atrial fibrillation, but there were also paroxysmal. It's a relevant question because you may be tempted to think, okay, because maybe this population was selected, so mostly paroxysmal. And in paroxysmal atrial fibrillation, we know that PVI works well. Persistent is not that clear, but this emphasizes more the benefit of catheter ablation, because even in this population of persistent or long-standing persistent patients, and that we know that there are many recurrences, those that didn't recur, let's say, provide enough benefits to demonstrate or to have positive results in the trial.
Okay, if we don't have any more questions from Dominic, we can move into case resolution. Please, David, you can continue.
Yeah, thank you very much. I mean, we already discussed a lot of the aspects that I will show you now. Actually, the timing question was excellent because, as you will see, this is usually not a one take resolution of the case. So we decided to have the patient on cryo PVI. And as you see here, these are the angiographies of parts of the atrium and the pulmonary veins. And you will see that this is much more dilated than expected after seeing a 48 millimeters LA in the echo. So this shows us the echo sometimes underestimates the dilation. You see that here the sheath and also the catheters have some difficulties to access already the ostia of the pulmonary veins, which can be challenging during the procedure. Here you will see that this was really challenging. If you are aware how usually the balloon in a cryoballoon ablation approaches the vein, you will see that the torque was substantial, and this was really difficult to have a good occlusion of the veins. This is more a technical question, but it shows us that in dilated hearts, the usual material can be challenging, especially if you look at the left upper panel with really some torque on this catheter and some loops. But at the end, we isolated 4 veins. The patient had an uneventful course and was discharged in sinus rhythm and felt very well. But he presented in our emergency room after only 5 weeks with now a very regular tachycardia, and you see that this patient was in atrial flutter now. And of course, this was not the plan, but it shows, okay, we have to decide not only about one PVI, but also about the sequelae later. And the question again is, and I will show you the next poll question here, what should we do about this? So, and the options are quite the same. We can intensify rate control, we can re-challenge amiodarone, we can re-ablate, or now go for AV nodal ablation. But Dominic, this is 5 weeks only after the first one.
Okay, so you have 30 seconds to make your choice about this management of not AFib recurrence, but atrial tachycardia, which is something which is common, I would say, after ablation. This
not unexpected.
Yeah,
of
not
course.
unexpected.
Secondary tachycardias can originate after 5 weeks, 5 months, 5 years.
Okay, just quickly the result of the question. Rate control, no. Amiodarone, no. Re-ablate, 33%. And surprisingly for me, 67% will go for AV node ablation. What did you do?
Interesting. Yeah, I didn't expect that, especially after our discussion 5 minutes ago. But yeah, I think all are valid options. First ones are maybe not very promising, but feasible. I mean, if you go for operation of the thyroid gland, you can still give the patient amiodarone later. You can go for AV nodal ablation immediately, but 5 weeks later, and for a macro re-entrant tachycardia, we decided to re-ablate the patient. And this was the ablation. As you see here, this was micro re-entrant around the mitral valve. It terminated under ablation, as you see here. So this is something we as electrophysiologists like. But you also see large areas of low voltage in this map on the right upper panel. So we also had some more substrate ablation, exclusion of the posterior wall to exclude these low voltage areas. And this resulted in non-inducibility of any other secondary tachycardia, and the patient was discharged with this beautiful sinus rhythm and resynchronized ECG. And the long-term follow-up of this patient was the AF burden dropped from 35 to 1%. Biventricular pacing was elevated from 85 to 98%. Ejection fraction slightly recovered after 6 months to 42% and even to 45% after 12 months. NT-proBNP dropped, and the patient was not re-hospitalized for heart failure or for any atrial tachycardia, and this was a very good follow-up for the patient, and he was very happy. Thank you.
Thank you. And luckily, we had good outcomes for the patient. And now we will move to next speaker, Professor Axel Brandes from Denmark. And the lecture will be about follow-up and living with heart failure after AF ablation.
Thank you very much, Izabella. José has already told us that atrial fibrillation and heart failure are two vicious twins. They can worsen each other, and they share common risk factors, and there are multiple mechanisms by which heart failure can lead to atrial fibrillation, but also atrial fibrillation can lead to heart failure. So this is, I think, common sense today. And also ablation, we've heard a lot about this treatment option already today, is an integral part of holistic atrial fibrillation care today. But certainly there is a before and there's also an after ablation, and this is very important. We have already discussed shared decision making, and that should start from the very beginning of the course of the patient. It is extremely important in relation to ablation, invasive procedures, but should be done during the whole course. I would like to focus a little bit more on the after ablation period, the follow-up, which is necessary in these patients, but due to the coincidence of atrial fibrillation and heart failure, it may be more complex because we have to tackle the atrial fibrillation management, but also the heart failure management. And what is important to go for, we should of course know about the rhythm of the patients, but also the heart failure status. Many patients will need optimization of their medication, both in terms of atrial fibrillation, but also in terms of heart failure. And many of our patients with atrial fibrillation and heart failure also have other comorbidities and lifestyle factors which we have to focus on. And that means that patients need proper education about their disease, not only for self-management, but also for adherence to treatment regimens. A lot of patients may have psychological issues in different stages, and this is also important. And of course, we want to know what the LV function is. Do we can we do something good for the patient with the ablations, and will LV function improve? That's important to know after an ablation. And what is also increasingly important is to assess rehabilitation needs in these patients. How can we do it? I think the best way to follow up these patients is to stick to integrated care with the patient at the center, receiving personalized education, empowering the patient to self-management. We should use shared decision-making whenever possible, and also educate patients to lifestyle modifications. This is done ideally by multidisciplinary team which is composed according to the patient needs. Not all patients will need all specialties, but many patients will need more than just an electrophysiologist or a heart failure specialist. And it's also important to do a structured follow-up, taking care of both stroke prevention, rhythm control, symptom control, but also management of comorbidities and risk factors. Luckily, we have also a growing body of supporting technologies with digital solutions which may help to do these structured, integrated follow-up care. And a question we regularly face in the consultation with our patients is the patient has had an ablation and feels very good, no signs, clinical signs of relapse, and of course the patient said, do I still need anticoagulation treatment? And the question of the audience is, would you continue oral anticoagulant therapy after successful AF ablation in these patients, yes or no?
Well, thank you. It's a very practical question because we have many patients. We come for the discussion of AF ablation, and they are totally convinced that we will succeed. The patient, he will be in sinus rhythm, and so he can stop anticoagulants. And now people are voting, and I will give you the result during the discussion. Okay. Go ahead.
Yes. Yeah. There is some evidence already. This year at the ESC Congress in Madrid, the Alone AF trial has been published. It's a study from Korea, which included patients after an ablation and randomized them to either discontinue oral anticoagulant therapy or to continue anticoagulant therapy. As you can see, there were quite a few events in both groups, and the significant difference was mainly driven by bleeding events in patients who continued on anticoagulants. But it is also interesting to see that there were more strokes in patients with who continued anticoagulation and then in the group who discontinued. So that is important to note. This study is probably not an ideal one. There are limitations. Patients were not continuously followed on their rhythm. There was no continuous monitoring. The patients received a Holter every 6 months. In terms of age of heart failure patients, only 15% included in this study had heart failure at all, and there's a sub-analysis. Should always be careful with these sub-analyses, but there was no benefit of discontinuation in these patients. Another aspect is that 2/3 of the patients had paroxysmal AF ablation, only 1/3 persistent, so they were probably healthy and also a little bit early in their AF ablation course. Another question is, are these results generalizable? Because these were East Asian patients, would the same apply to, for example, in the European cohort? We can question that. And these patients were relatively healthy. They had a median CHA2DS score of 2. And if we look again at these subgroup analyses, so there was no benefit, for example, for patients who had a CHA2DS score of 3 or more. And these patients were about 30% of the whole cohort. Another aspect is that the median left atrial dimension was 40 millimeters, and that speaks a little bit for it. There probably were not that many patients who had a very pronounced atrial cardiomyopathy like your patient, David. Had certainly much more atrial cardiomyopathy and probably these patients. So I think in light of the current data, we need more data to decide whether to stop or not. There are trials underway. The Ocean trial is in its follow-up period right now, and there are several other trials looking at an on-demand approach. Right now, I think heart failure patients are not the best candidates to stop anticoagulation therapy after even a successful ablation. If patients prefer discontinuation or insist on it, this, I think, requires a thorough discussion of risks and benefits with the patient, and at least a close rhythm monitoring to detect possible AF recurrences, so anticoagulation therapy can be resumed. Another option may be, and we get more and more data on this as well, left atrial appendage closure, at least for selected patients at this moment, but more data are underway, and I think we will get more evidence on this as well. So my conclusion is the multidisciplinary, integrated and structured care in patients with atrial fibrillation and heart failure is key. At least there should be a close collaboration between EP and heart failure specialists, more than we see today. Follow-up may be complex and should be individually tailored according to the patient's needs and preferences. So there's no one-size-fits-all. We have increasing supporting technologies, digital solutions are being spread now, and they can aid our follow-up. And I think it's also important to stress that shared decision-making always should be used where appropriated. Thank you.
Thank you, Axel, for this wonderful presentation. And I think you mentioned something that we hardly talk about, and I would like to ask all of you questions as cardiologists, because you mentioned also accept patient-integrated care and patient education, multidisciplinary teams. Of course, we like those topics. And you also mentioned psychological issues within this group of patients. And this year was released the position statement from the ESC on CVD and mental health. And exactly in this statement was highlighted that we should screen the patients for depression or anxiety. So what is your opinion on this? Should we focus on this? Because I've heard also that we can expect worse outcomes if the patient has a depression and is undergoing ablation.
Yes, I think we should screen these patients, and if they have an issue, a psychological issue, anxiety or depression, we know that outcomes are worse. People do not adhere to the treatment, the atrial fibrillation and heart failure treatment, so it's important. But that will also require that there are enough psychologists to treat these patients. So that is another problem.
Yes, to come back to your question, 100% of the attendants did not stop the anticoagulants.
Yes.
And
Congratulations.
I think it's a reasonable answer, because people were very excited in Madrid at the ESC with the presentation of LONA-F. But as you mentioned in your slide, there was many limitation for the ethnicity, which is different from Europe, and also there were not so sick patients to be, and I think it's important. So I think my personal advice is, okay, LONA-F is important. It's a nice trial, but so far we do not have the evidence to change the recommendation. And patient, after even successful, and it's not very easy to define what is successful, AFib ablation, should be under anticoagulants. I think that everybody agree. Jose?
Yeah, I fully agree. The interesting thing is that this patient, the patient that you presented, Rapid, is CHA2DS3. And the alone trial included patients with CHA2DS2, but rank between 1 or range between 1 and 3. So theoretically, it may apply. However, in the long trial, patients should be without atrial fibrillation for 1 year, so this is not the case. And secondly, I am not sure if all CHA2DS components are the same, because we know that heart failure in particular is a little bit tricky. Yeah.
I think another problem is the monitoring. So these patients had only monitoring every 6 months, and we all know that after ablation, atrial fibrillation events without symptoms are more common. And so these maybe not have been seen there, and they are as dangerous as the symptomatic ones.
I fully agree, because we don't have any data about the real burden of AFib in this population. So,
but on the other hand, we have a chance in this special population because most HFrEF patients have a device, and even if they not always have an atrial lead, still the device could give us some information about the AFib burden, and maybe we can learn how to manage this based according to the burden. Maybe this plays a role. We still think this plays a role. We don't know where the cutoff is, etc., for this decision, but I see a chance.
No, I fully agree. I just want to come back about the multidisciplinary approach, which is what we have to do, but what is not really done in daily practice. Because I think now for heart failure, it's more clear, but for AFib, I'm not sure that many centers have a specific pathway, including especially allied professionals, because they are very keen to provide education and also patient adherence and so on. But I think that most of the center, patient came for ablation, he got the ablation, and after the patient is not followed by the center. So do you have in your institution, for example, do you have a specific organization for that?
Yes, we have. We have an atrial fibrillation clinic, and I can say in Denmark, in many hospitals, there are atrial fibrillation clinics. So they have been there since 2012, where the first clinic started, and this is quite a success, I think. But it requires a structured approach, and if you have this structured approach, then I think it's easier to gather all specialties. Otherwise, it's difficult because we all know it's very difficult to find a doodle poll where all people can, and it's a problem also with these patients. If we should. This is a practical question. If we should gather for one individual patient to make an individual treatment plan, and we have 5 or 6 specialties, it's not easy.
Yeah. Congratulations. I'm not sure that other countries are so far with the AF clinic. We just started. And as you mentioned, I think it's very important because we know that the control of risk factor and especially obesity is very important in the long-term outcome of AFib ablation, and this was shown by Pat Sanders from Australia. We did show that when you take care of the weight in your patient who had successful AFib ablation, if you can decrease the weight, you increase the long-term success. So I think it's very important, and I think it's the way to go. And for this, we have to be helped by a lead professional, because a physician, of course, cannot do everything. So I still have one question, not from Dominic, but from another person, about what is for you, it's a difficult question, what is for you the definition of successful ablation and how to evaluate?
I needed to give a talk on this, so I more or less. So there are many different definitions. To date, we have been using in most trials the time to the first recurrence. However, this is probably not very clinical and meaningful because 1 minute recurrence, it doesn't make a lot of sense. So now we are slowly evolving to a burden, adult fibrillation burden, that is more meaningful, especially for heart failure and stroke risk, because we know that the strokes depends of atrial fibrillation, but the time in atrial fibrillation, so burden is important, and also the underlying atrial cardiomyopathy. So I think that burden is important, but then at the end, clinical endpoints are more important.
David?
Yeah, I think this that we need to consider the burden. The goal of the AF ablation is not elimination of atrial fibrillation. And if we look at, for example, the Castle trials, Castle AF and also Castle HDX, we saw significant effects in hard clinical endpoints, but the burden was not zero in the intervention group, but it was a significant difference in AF burden. So this must be a component that we need to consider, and for me it is part of the success of the therapy. But again, here we need to talk to the patient and make him or her understand too that it's not a surgical technique to exclude atrial fibrillation, but it's a reduction in AF burden, reduction in symptoms, reduction in progression, and all this will contribute to the success of the therapy.
Okay, I can see that Christophe is looking at me to make the wrap-up of the session of this webinar. So today's discussion highlighted how atrial fibrillation ablation may become an integral part of heart failure management. We were talking that it might be the fifth pillar alongside guideline-directed medical therapy devices, lifestyle intervention, and advanced therapies. But mostly, I thank everyone who was today with us for all those difficult questions, for questions from Dominique. So we say hello. And first of all, and last but not least, I would like to thank my coordinator, Professor Leclercq, and my wonderful colleagues who were joining us today, Professor Merino, Professor Brandes, and Professor Duncker, and myself. And
thank you very much. Just if you allow me a final comment from Dominique. Yeah. So I think it's a very smart one because it was that medical therapy is often different between EP and heart failure specialist. Mm-hmm. I agree. Mm-hmm. Is the patient of the 4 pillars, in bracket EP, or are there maximum target dosage, HF? So I think the conclusion, team playing is very important, and I think it could be the conclusion of our webinar. And it is also the goal of the iHF program to have a translational program, including all the subspecialty of cardiology, but not only cardiology, of course, allied professional. I hope you enjoy this webinar, and I just ask you a final task. Just save the date, because in the city of Madrid, we will have our first iHF annual course on Friday 20 and Saturday 21 of March 2026. So I hope we will see most of you to this meeting. We will be based on clinical cases with very practical discussion and with a multidisciplinary approach, which is a new way to treat our patients. Thank to all of you, and thank you for attending this very exciting webinar. Thank you.